I will help this. I'll enter the. Hang on. I will enter them.
Sure.
Thank you. Thank you. There's more coming, so I'll just keep doing this. We should get about to 90. It's just hanging at 90, 100 today, so we just wait a bit longer. Just give him a call, Pooja, please. He's waiting for your call. How many are there?
Dr. Sarkis, we had 223 students registered, so we might have to wait a little.
I'm happy to wait. So
yeah, just
a question I can ask you. Look, let me do this.
Yeah.
Let me Nimesh, I might throw your case up. 1 second.
No worries.
Okay, you don't mind if I do that? So okay, I just go to new share and new share. Okay, screen 1. Okay, can you see the screen? Can you see this? Can you see these pictures? Yes. Nimesh, can you see it?
I can see it. Can you enlarge it?
Yes. Can you see the image? Yes.
Yeah, we can see the image. Yeah, it's a front view. Yeah.
Yeah. Okay. All right. I'm just waiting for participants to come in. Just quickly tell me: is a patient? How old is the patient? Female? How old is the patient?
She's 60. Yeah, 58.
Okay, 58. What's the medical condition like?
Medical condition, as such, there is no health issue. Health is fine. It's just the
experience, right? Okay.
Yeah, it's just a very traumatic experience.
Okay. So you get considerable crowding. Okay, understand that. There's a little bit of wear. She's on a premolar. Is it premolar occlusion mainly? Yes, looks like it. Okay, so she had upper crowns done, and she likes to color this tooth number 2, 3. That's a recent crown. So she's come to you to basically fix the teeth. Is that correct?
Yes.
Okay. Understand. Okay. Well, just one more phone, waiting room, admit. Okay. What about okay, so here's the x-ray. Okay, here's the x-ray. Just to get the therapies. Okay, let's assume they're adequate. Let's assume period is work, but we'll talk about that. Here's the occlusion view. I'm just looking at different angles. So here's the occlusion view. You can see there's a crown there. There's a composite restorations, etc. You probably wonder why they put this crown in the first place, but that's what people want to do. And there's a crowding and a plaque retention. We need to look at the perio here anymore. I've just only loaded main pictures, okay, here, so you can see it. So the question would be, I want you to start. Oh, Dr. Sanzin, fantastic. So think about this case again, one more time to discuss at the end of the day, and we'll talk about it more. Okay, I'm going to go new share. Going back to the new share. Okay. Stand high. Okay. You gotta unmute yourself so you can. Can you hear me, Stan? I can't hear you. Unmute yourself.
You should be able to hear me now. How's that?
Fabulous. Well, Stan, thank you so much.
You're welcome.
And it's sincerely, to me, not just only a pleasure, but it's we've known each other for a long time.
Yep.
Each other on a professional basis and personal basis. You're my mentor over the years of time. You're my periodontist I work with, and you've done some marvelous work. And today's case, you haven't done anything. You're just going to be commenting. But we'll have lots of cases we shall come into and discuss some of the soft tissue, some of the marvelous perioplastics that your expertise in those times will be much appreciated. But today I like your commentary because you're a periodontist and implant surgeon. You place implants, and you've done a lot of work for me. And we all know it's one of those complex subjects in dentistry.
Thank you, Sarkis.
Thank you, thank you. Everyone's still coming in, Stan. I'm happy to leave it a little bit longer, but we should get about 100 number for sure. But by all means, we had a lot of participants participating. But I mean, we got 80 people, and they're still coming in. So I'm hoping to.
Not too far from where you are. There's a place.
Me and Stan will be on the unmute button because we'll be talking about this. Would you please unmute yourselves unless I sort of ask questions or you have a question to ask? Happy to answer it. You're most welcome to stop us and ask a question. This will be a very, very valuable lecture series for most of the colleagues. And one of the reasons is that we'll talk about the planning, the concept, the emergencies that we have, and the possibilities, and how do we simplify the treatment for our patients. I think Stan and I would agree that most of the time we prefer to choose the simplest and predictable treatment. We find that the more complicated people try to plan, which not only increases the biologic burden and financial burden on patients, but there's a number of risk factors sometimes gets ignored even by the best people. I think implants can fail in the best pair of hands, I can assure you that. And we know this. So without much ado, I'd like to proceed. First, I'd like to thank Dr. Stan Boyatzis, specialist periodontist. You have his history on the website. Stan, you've been responsible for training postgraduate students for as long as I can remember. I think you have the best name in the faculty because you teach with your heart, and also you teach with your mind. It's an important, I think, a quality as an educator you possess, and I value that very much so. And I really thank you for being part of this lecture program.
Thank you, Sarkis.
Thank you. Today's lecture is about failing dentistry series, the second part of it, 16 and 17. And particularly, this was referred to me by a very good general dentist colleague. He said, Sarkis, please take care of this because everyone's done what they can. I think patient needs to see you. So when you see this particular prosthesis on my mirror, it is at the time that we almost presented with the patient. So we need to really move on this lecture. So patient has had pain for 8 years. That never stops. She explains to me that the pain never stopped ever since implants were put in. So we have a problem with implants placing in the mouth. It was placed by a maxillofacial surgeon, irrespective of placement, and patient had constant pain. It actually never stopped for 8 years. So we'll talk about the treatment planning. We understand, the diagnosis, short and long-term options, but people are living longer today, and they're living longer. They can see on the media that, all of 4 come to my surgery and will get you walking teeth in an hour, etc. And she falls under the impression that this also applies to her, and people do this often. It applies to them, so they go and have dentistry done, and that's all very well. Well, it's fine because we all want to do the best for our patients, and when you think seriously about this, and we talk about the rehabilitation of maxilla, or terminal implants supported. We talk about terminal dentition. Now we're going to talk about terminal implant supported dentition or prosthesis. You can see the period of time that there's been a kind of constant bone loss for a long period of time, good 8 years, over the 8 years of that time. And you can see on the lower arch there's a there's a minimal dentition presence. Here's a shorter than an arch. There's a partial prosthesis, which I'll show you later on. That's present there, and the patient is basically looking at treatment options. And it would be very interesting to see from the patient's point of view. Unfortunately, I cannot show you the recordings because we cannot show the identity of the patient. But this is how she presented my practice. The sad thing that I have is I don't have any facial photos of her or records of her before the treatment because she was in such a difficult moment that I just didn't get a chance to take those photos. But nevertheless, when we talk about this patient, let's look at the history of this case. And, failing implants, constant pain last 8 years, that never stops. And I just want to eat and smile again. And as usual, the husband comes with them because her life is hell and also his life is hell. He wants to fix a problem so they can get on with their lives. And in many ways with these patients, we put their lives on hold and we do quite a major reconstructive work. And when you look at the expectation of this patient, all she wants is comfort, normal life, aesthetically pleasing prosthesis, okay? So when you think about it, even after all these years of wearing this prosthesis, okay, she was not happy with it. So when you think about it, she was promised to have a really good looking teeth and nice teeth and beautiful teeth with implants. After 8 years of constant pain, she's still not happy with it. And of course, it's not a concern for this patient. So when you think about it, that's an interesting story. So the question I like to ask my patients, I'm looking at them, is their history, their medical history. And the medical history is an interesting one because she's got, well, penicillin allergy doesn't worry me, but depression does. Antidepressants do, serostomia do, and there's nervous breakdown in 1997-2001, because some psychiatric care. The implant therapy started 2006, I think, and that's way after this therapy, after the treatment or what she had. She's on the constant care of psychiatric psychiatrist, and 10 years of history of the prosthesis wear. Stan, would you like to come into this area? I mean, what's your thought pattern so far?
Basically, with the medical history, obviously that is critical. You've gone through depression, antidepressants, drying effect that they can have with the antidepressants, plaque control through a periodontal point of view, and xerostoma. So those two you can relate together. There was no other medical history at all, nothing else relevant?
Nothing else relevant. Basically, she's on heavy antidepressants. There has been some articles that have tried to link that to, and the proton pump inhibitors to the implant failure, but that's not really, any association. It's just probably more part of the parcel. But she's also a severe bruxer. She's a severe bruxer. Her oral hygiene, I guess, would have been compromised to a degree because of the dry mouth and plaque control. I mean, during the period of, I guess, when you have depression, you have your, periods of depression. So that would have been a problem in terms of her maintaining the oral hygiene. But I think the question I would also ask Stan is, what was the reason for loss of these maxillary teeth and mandible teeth in the first place? Would you agree? Like, we know it's a periodontal disease, and I think having a history of periodontal disease, does it increase the risk of loss of bone around the implants?
Yes, that is a risk factor, and there is a correlation with patients who have periodontal disease that they will have peri-implantitis.
That's right.
So that is something that you have to sort of stabilize before you start putting implants in those patients.
That's interesting because there's no periodontal chart. You see, when I inquired about it, there's no periodontal charting of the attachment levels present for this patient. And that to me is now, going to the next slide, looking at past history. This was the initial presentation, 2000. Pooja, can you unmute the person, please? This is a 2005 presentation. And obviously the last teeth in standing, there's a loss of support. I mean, they just about can't be saved. And you can see there's a premolar present here. There's an infrabony pocket present here. What else do you see here, Stan, that would be of value?
Well, if you look at the maxillary arch, that's terminal. Those teeth are terminal, right?
Right.
So there has been progressing periodontal disease.
That's right. That's right. And I'm seeing infrabony pockets here. And just from prosthodont's point of view, whenever I see big fat condyles, it really tells us the patient's probably severely bruxing. You know, this is all clenching. There's always a chances, or they've adapted or they've gone bigger, so it takes a lot of loading. Even a very skinny lady. So this is implants placed in maxillofacial surgeon. That's 2006. And X-rays are not very good, I'm afraid. But looking at this, you can just see that there's a problem with although X-ray is not accurate, I'm sorry, but that's all I have. It's not my X-rays. I've sort of chased it around to get them. What would you comment here on, Stan, by just looking at those X-rays?
Do you have any PAs? That's the only radiographs you've got of that?
I've got PAs. I've got PAs that are here and there. I mean, this is at a time that patients referred to the dentist to take impressions, and that is the fixated cuttings that was taken at the time. And it's quite obvious that there's a considerable bone loss during the impression taking procedure. So these implants were losing bone even at the time that impression was taken. Would that be correct?
So how long was it since they were placed to the impression taking?
I would say, I assume that would be a good 6 months. You know, I think all surgeons would like to wait between 3 to 6 months. But I'm not sure.
So you've lost, say, 4 to 5 threads already.
Absolutely. There's a lot of loss of threads, and I'll explain a bit more later on. Let me just show you a bit more here. And that's when the prosthesis was connected in 2007. Okay, that's connected to 2007.
Yeah.
And attachment was done, but just coming back here, we can see well, it's very hard without a PA, but I do see some bone loss here. I mean, it's very hard to say, but I do see some bone loss here. And there's the constant pain. The infrabony or widening of periodontal membrane is quite considerable here. S is here, Stan.
Yeah.
I also had a chance to look at the bone level. It's about, I'm still looking at it at a different angle. So there's quite a lot of loss of bone. That's actually not what you see. It's actually, when you look at the periodontal area, there's quite a bit of bone loss there too. So I've been managing this patient. They've been managing quite a while, and just showing the clinical images of the patient. At the time when she presented, this is her earlier time at 54, and this was an upper denture placed to reline, and this denture was converted to full denture. And I think during the period of time, they were having implants. The full maxillary prosthesis was basically been worn over the healing implants at the time. I think that would have had some sort of a reasonable cause for the healing above the shoving and loss of bone. Would you agree on that? Or
what do you think of the position of the implant? You probably can't see it. It's equivalent. Which one are we looking at? Yeah. That one there. Yes.
One. Yes, absolutely. Absolutely. Well, I can assure you there was no surgical guide used here. It wasn't prosthetic driven. It was just placed at different angles. And you can see how the implants are placed here at different angles, and basically it was sent to the general dentist to fix the problem. I couldn't see any surgical planning here. This will be part of the important discussion later on, which I have a few questions I'd like to discuss. But nevertheless, it's quite obvious here. This is all sent to me by the dentist. It's not my X-rays. It's sent to me by the dentist. This is the time when they saw the patient to restore. And this is how the patient presented clinic for restoration. So it's quite obvious that this is the denture that we should be wearing at the time. Let's look at the patient here, 2006, when she presented. Very vibrant, lovely woman, and wearing a denture. I mean, implants. I'm not sure implants are countersunk, or looking at her time, and she had a considerable bout of depression and illnesses, and suffered and been treated on the psychiatric care for a while. And so during the time, this was relined viscogel. You can see the viscogel, the soft lining or a denture. But nevertheless, this is how the patient presents for the final prosthetic reconstruction. Any comments? The other thing I can say is that you can also see that tooth number 4-4 is drifting distally. Okay, so that's at the time. Any comments or any questions? I'll proceed. When we sort of looked at the initial assessment, you can see the lower arch, the attachment levels. Now, it seems interesting, especially for 4. I think that there's the infrabony pocket formation, so I wasn't quite happy with that charting. But nevertheless, this is what patient presented with after, I would say, 10 years. So, and we have a considerable bone loss. The implant here had penetrated nasal fossa, and there's a complete loss of bone in this area. There's basically the whole prosthesis is almost mobile, so patient was in a complete panic situation. And we saw this patient immediately. It was referred by dentist. We didn't wait too long because I could see the problem happening. But when we look very, very carefully, during that time, tooth number 3-4 was lost. You can see from previous lectures, previous images. And at the same time, you can see the infrabony formation from here. This is a classic example of incorrect prosthetic design as well. And because of the type of prosthetic and the clasping and the loading that's placed on the terminal tooth. Remember that both number 4-5 was crowned to be able to close the space because the patient was aesthetically conscious. So was 3-5 was crowned to close the space. So any comments you'd like to make, Stan?
No, there's been drifting. Obviously, there's progression, whether it's an occlusal overloading or it's periodontal disease, but you can see it moving across. Mm-hmm. So you don't know time-wise between when that started drifting again?
That I don't know, because basically this has been, you can see have removed maybe about 2 months ago, 3 months ago. It's healed. You'll see the area. So I would say timing-wise, that would be maybe 3 months before the patient presented in my practice. That's completely almost healed, closed up, but the bone defect is still there. Mm-hmm. But you can see that there's a problem here. And that's because of the incorrect prosthetic design of the partial denture. I mean, this is not taught, unfortunately, in dentistry today. And every one of the students want to know how to do 1 or 2 day composite restorations or 1 or 2 day quick veneer fixing. But this is a everyday bread and butter dentistry that's actually not being taught. And we're trying to teach us also studying in college how to plan restorations, how to diagnose, and how to think about these cases and look at the patients overall. And I think in many ways, this was omitted, even by the surgical colleagues. This should have been taken care of. I just want to go to the next one. We can see we talked about this. And when a new denture was placed, again, you have a T-bar. And T-bar on the terminal dentition is just a wrong type of clasp design. It's like a corkscrew remover. It basically destroys the distal buttons as it did this one, especially the premolar here is actually 4-5 with the thin, slender roots, with a strong root support, and again, it's a fixed type of restoration, such implant support restoration. The patient's severely clenching. She's actually clenching and bruxing, you can see. And, you know, when you're under depression, you do a lot of these things. You tend to sort of grind really hard, minimal saliva. So the effects of the bruxing is a lot heavier on the teeth, as well as on the periodontium and the attachment levels, as well as on the prosthesis. Are you happy with this so far, Stan?
Yeah.
Any questions from the participants? Anything at all?
Dr. Sarkis, Namita Mehta asks, what kind of prosthesis design would you design for the lower arch? Or are we just doing the lower arch later on and just discussing the maxillary right now?
Well, a good question.
Yep.
Can I answer that question later on? Because
Yep.
That's a very, very good question. Because see, we still need partial dentures. We still need full dentures. These are important parts. I mean, implants are not indicated for everybody. Okay, although the success rate of implants in the mandibular area is very, very good. And many of you would have said, well, why don't you just take this bottom teeth out and do your alveolectomy, and then you place the 4 implants. And that's very well said. Don't forget, this patient had 6 implants failed, been suffering with pain for the last 8 to 10 years. So that's something we need to think about, okay? But the design, I'm happy to talk about design. And as a matter of fact, with the college, we talk about in module number 9 in removal prosthodontics, we talk about how to design prosthesis. Dentists are fortunate, given their livelihood of in the removal prosthetics to the dental prosthesis. And I know I have a few colleagues who are really good friends of mine who are dental prosthesis, and dentists should be able to design their own prosthesis. They should be able to make their own prosthesis. They should be able to do a good level of prosthetic care to their patients. And unfortunately, that art has been lost, and it's been given to other colleagues who do just as good job. But it is within your rights to be able to do those full dentures, do those partial dentures, design them appropriately. That will help you in managing your patients and improve for you to grow your practices. If you're losing the important knowledge of removal prosthodontics, that's a big part of general dentistry. If everyone in the world is going to do porcelain veneers, I can show you there's a huge room for anyone who's interested in doing removal prosthodontics. I mean, I do a lot of porcelain work, but removal prosthodontics is a very, very important part of any general practice armamentarium. Everybody loves the implant prosthodontics. Everybody loves the porcelain veneers. They love the composite constructions, okay? And I agree with that. But the design of this has a lot to do with the diagnosis and treatment planning. It has a lot to do with occlusion. It has a lot to do with maybe you can use composites to reconstruct lower arch before the tooth-way management. So they all go fit together. And sometimes I've been asked to look, you know what? I don't want to do this whole course. I like to do only that one. I said, well, hang on, are you going to ask me about occlusion? Yes, it's module 3. Are you going to ask me about, well, how did you work that out? Well, it's diagnosis and treatment planning. Well, how can I talk to you about porcelain technology when we haven't diagnosed this case? We haven't done proper assessment of the patient's attachment levels, their occlusion, their dental-facial aesthetics, the vertical dimension. All those things are part of it to get good results here. So, this is the biggest problem I'm facing, because no one wants to sit down and learn, or those smart ones want to sit down and learn and get a good education. And if you do 1 or 2 day courses here and there, who's going to connect them for you? And that's what we do here. So thank you for that question. Coming back to the actual lecture, we did dental level analysis of this patient. All the prosthesis there, while the patient's very, very apprehensive. So look, I've got to do a few things. Let me have a look at you. And you can see that sure, all the sounds are clear. You would expect so much air space. Patient unable to say the lingual dental sound, the palatal-lingual sounds. But the funny thing is that there's so much hypoplastic tissue here, Stan, that it actually seals all this area, and she can speak very, very normally. And when you think about this, we need to do diagnosis. So I think about this case. I said, well, what is my diagnosis? And looking at the lower arch, you can see the loss of internal papilla there. So the patient said, consider the amount of periodontal bone loss. So it's subject to periodontitis for a long time, okay? And unfortunately, this is never ever taken into account in your overall treatment planning. Stan, would that be correct assuming this?
No, that's correct.
So moving along, diagnosis and problem list. 65-year-old female with failed maxillary dental implants, supporting maxillary fixed dental prosthesis, has a chronic pain for the last 4 years. I mean, we have chronic pain. Let's look at the problem list. So we need to do a problem list for every patient. If you're going to treat them on a multimodal scale, if you're doing, overall multimodal treatment where you have multidisciplinary people working on it, periodontal bone loss, she's got chronic pain, constant pain, 5 out of 10. This woman is in pain all the time. Okay, so we have to remove the failed implants. That means all the implants and assess healing. The question is, you remove all the implants, what happens? You're going to let the patient go toothless? Can they tolerate it? Okay, and although we look at the history, she wasn't able to adapt to the old full dentures. That was the reason she wanted implants. She was promoted to have implants. Okay, and what happens when you lose the implants in the maxilla? I mean, how much bone do we have left to treat these patients? So you're going to think about the consequences. Whatever we do in life has consequences. How do we deal when things go wrong? Your contingency planning. Okay, we have poor residual ridge form in the maxilla. Okay, we need to see, the patient adapting to, well, what we're going to do. We're going to have a complete maxillary denture, aren't we? Because there's no other way. This patient's worst fears has to be realized. But the patient is so much pain that she's happy to do anything just to get out of pain. So tooth number 4, 5, or 4, 5 is guided prognosis. Okay, we want like a periodontist to assess and adjust and assess the gum levels, do SPT, SRP, and maintain the patient on SPT, which is supported periodontal therapy. Okay, we need to modify class design. I'm going to talk a bit more later on. And how do we modify class design is basically remove the T-bar on the terminal tooth, and most likely, because this tooth is very traumatic, I would go distal the 4-3 and use a special signal of rest and be able to redesign denture that way. Okay, Nitin, so I think that was a very, very good question. Thank you. And you want to provide a stable context for this patient. Now we know what treatment options in the maxilla. Okay, removal of dental prosthesis, which is a full upper denture, is the best thing. You've failed implants, and patient wants a satisfied, motivated solution. Okay, and we know that the full upper dentures are very well tested modality over a couple of 100 years. Okay, we want to reduce the maintenance burden and biologic burden. We can do beautiful aesthetics also with the full dentures. There's no need for surgeries. There's no biologic and financial cost. Now, if someone mentions to the patient that, oh, we can do more implants, you can do zygomatic implants, you can do cord zygoma, you're just killing these people. Okay, and in many ways, simple treatment is probably the best. So you make a plan. Okay, improve oral hygiene. Okay, they do the diagnostic wax of all these important things that needs to be done. Okay, modify mandibular prosthesis. That's very important. Okay, so we make a treatment like a diagnostic maxillary denture, full denture. Okay, maintenance protocol is very important. It starts here, not at the end. I know we're going to go through definitive treatment here, and there's a maintenance, but maintenance protocol starts here when you're doing the initial stabilization phase. Stan, would you please comment on this, especially on patients with periodontal bone loss, and how important is the maintenance program when you start to treat these patients?
With maintenance, as I said, I'm still want to go back to that 4-5 because I'm still not sort of convinced what's happened. What were the probing depths around that tooth? Sorry to take you back.
No, I think 4-5 probing depths is more like a 7 millimeters, 8 millimeters. It's wrong on the charting. Okay, it's more than that. I think the angle of the probe should have been angled a bit more distally. Unfortunately, it wasn't. But when I look at the X-ray,
was any treatment done? Any periodontal treatment done on the 4-5?
No, the patient visiting, no.
So would you retain that tooth on a long-term basis?
Well, initially, I will retain that tooth, but I will redesign the prosthesis to do the supporting and retention of fall free. I will redesign it. So that tooth is more or less free. It is basically a power treatment, but I will then decide which way to go, because taking a tooth out at that point of time for this patient is very psychologically upsetting. So that was one of the reasons I would consider.
That's fine. What you've got for the maintenance there, I agree. Access oral denture hygiene, change in risk factors, right? Local and systemic caries risk. How do you assess a caries?
Well, basically, risks are here. I'll just go back. Okay, salivary, salivary. She got dry mouth. In other words, when we look back, there's actually a proximal caries there.
So she's more a periodontal risk than from caries, right? Losing those teeth.
Yeah, more periodontal.
Yep.
Periodontal. More periodontal. More periodontal. So what really happened in this particular case is coming back is the implant basically fell off during the impression taking stage. And what we had to do is do a number of emergency procedures for this patient. But I like the quote from Terry Walton's fan, where it says, "There's no fallback position unless extensive morbid reconstruction." So in other words, we have a patient who had a fantastic ridge to start with. Now she has flat maxilla, very difficult to construct full upper denture, but it can be done. There's no question about that. She has a dry mouth, so lots of water required to drink to hydrate the patient. I'm looking at prosthesis design. It's roughly convex on the intelligible surface. There's a couple of concave areas, but I don't think that's responsive for the bone loss. Would you agree, Stan? I mean, we had a bone loss to start with.
Yes. Yeah.
And you know, and this patient now at the age of, I think, about 65, should be considered as maladaptive, because basically, how is she going to wear a full denture? I mean, we're faced with a complex problem that we have to deal with. Okay, and no one actually understands, unfortunately, that when you do these complex problems treatments for these patients, they don't see that in what's going to happen in 5 years' time, in 10 years' time. Most things are okay in 5 years, but after 10 years, you get to see your real success rate. Because patients' risk factors change as well. The health factors can change. But this problem started prior to initial treatment, and it's difficult. It's difficult for anyone that has to meet these patients when you're placing implants suddenly of a large bone loss. And you know, the problems when you discuss this with the patients, very rarely we talk about to the patient that things can fail. Because that's the first thing I tell my patients, that things can fail. I mean, it can fail. And sometimes I prefer, Stan, to maintain even few teeth in the arch, and then take them out later on when integration is confirmed, and then look at that later on, because I feel more comfortable and doing this as a part of overall risk assessment of the patient, is what to know which way is this case going to go, because every patient is so different. Would you agree on that?
I've got no problems with retaining teeth, and if you look at studies like the Herspil-Wasserman study, teeth that were, condemned 22 years later are still there. The problem is when you start putting extensive prosthetic reconstructions on those teeth, what happens? And they've shown that even with those, once you stabilise the gum disease, Lindy and Neiman have shown it, etc., you can hang on to those. But these, I don't think her oral hygiene is ideal. Would you agree with that, Sarkis?
Agree, absolutely. We mentioned Wasserman studies in earlier last of seminar 15 quite in length when I was talking about it, and I think Esa Malati was there as well. And we talked about those important aspects of maintaining teeth, and in many ways I had a patient who had I think 4 or 5 remaining maxillary teeth, and I decided to hang on to those teeth. Now it's in function for 5 years. And she's on and off smoking, but risk factors are there, but it's much easier to maintain teeth in that situation than implants. Would you agree with that?
Yeah, definitely.
And the problem we have as prosthodontists is when these cases go to this extent, okay, we left it, we sort of left to save the day. I mean, we're happy to do it. There's no question about it. That's what we're trained for. We like to look after our colleagues. We always welcome our colleagues and as it concerns occurs. But then we have to face with this patient's emotional nightmares, emotional burdens, trying to reassure them and try. They're traumatized. These people are traumatized. This is exactly straight after I've removed the implants. You can see that it's all healed up. These are the gum flaps. And, they just healed very, very quickly. Didn't have to do much excision at all. But this is a difficult path we have, and we have to treat those patients. So what I immediately did for that patient, I just quickly got 24 hours, and I said, look, I need 24 hours to give you denture. So we took the impression. You can see that the actual whole maxillary bridge work has been dislodged from the mouth into the alginate impression. And here we are. And so we have the existing situation. So we use the copy denture technique. This is ideal well to mount, as the implants are excellent in retention and plaster mounting. So you can see it's mounted. We can open the vertical meshes slightly, and using a copy denture technique, I sat down and one by one replaced those teeth in the clinic. We tried this in the patient's mouth, and she was happy and regained her confidence. So we can just see within the train, and we also sort of improved nasolabial folds, give a bit better lip support. And again, the patient's happy because they're trying to restore the patient's dignity, their confidence. And this is a very important part of managing these patients. How quickly are you going to restore these patients to normality? We have COVID now, and everyday routine is screwed up. Imagine if you're in this position for this patient, how you feel if you were in this position. So we're trying to build confidence, and in many ways, you can see we tried them on different angles. This is before, and this is what we tried them in, the treatment denture, and patient's happy. You can see that this is before, and this is after the provisional treatment dentures are placed, and in many ways, looking at patient that we improved and restoring the dignity. This is within 24 hours I'll be able to restore this patient. And this is what we do quite often in my practice.
Dr. Sarkis, we've got one question from Ryan. Did the patient lose tooth number 4-8? And we've got another question from Namita, which says, is the patient okay with an upper complete denture instead of an overdenture?
Well, upper complete denture has to be complete denture because there's no implants to give you an overdenture.
Okay.
Okay. But she's obviously happy with upper complete denture. And I can tell you why. And this is a problem I'm trying to achieve in this lecture, is that, I mean, you think about all these important factors patients has, and here's the provisional treatment denture in situ, all right? And the construction of a good full dentures has been lost by the general dentists. You have lost that important art of making good dentures, and we teach this in the academy. We actually teach you real dentistry, good prosthodontics, just every day in your practice. People don't teach us important art in dentistry. Unfortunately, it's true because this patient is extremely happy. She can open the mouth wide enough with a treatment denture. And when you think about this, this is 10 years ago, this beautiful, vibrant patient. There's an extra aging during this time with chronic pain. Of course, you'll age so quickly with chronic pain. Now, if you construct a good maxillary denture, even as flat the ridge may be, you can have good retention, okay? Because there's other factors involved in denture construction, and the neuromuscular factors, patient. This is a maladaptive patient, okay? But helping the patients from a psychological point of view to adapt because a well-constructed prosthesis is an important part of a general dental armamentarium. Now, this is an important part of dentistry that has been missed, neglected, and given to the dental prosthesist to prosper. You have missed out the gold in your hands. Don't you think it's about time you learn all these important aspects of dentistry that was completely forgotten by general dentists? You know, we're restoring patients' dignity, not just replacing missing teeth. Okay, there's a lot of data. I mean, Talgi, this is a Lyndon Cooper's group, at 5,000 patients in the systematic review. We'll talk about it later on. And they had excellent success rate with full dentures. Only those patients who really feel psychologically they need to have fixed restorations, and very few amount in those group that was referred to have fixed implants and prostheses, and very few. A good maxillary denture is as good as it gets. It can improve the aesthetics, function, comfort, and psychological well-being of this patient. Stan, would you agree on that?
Totally, but I'm just looking, if she was one of those patients that psychologically she would not accept a denture, right? This is a great result, fine, she's happy to accept it. But you do get that occasional patient. How would that fit in? I'm changing the scope of your lecture. Sorry, Sarkis, but...
I'm happy to talk about it. Let's just continue on. Let's come back to it because I've got a lot of discussion, you know. I like you've probably the span in the whip, which is marvelous, marvelous. We'll try this, a final prosthesis. So we improve the outline, and you can see this is trying on the same patient. And obviously now we can have really improved the patient, you know, biopsychosocial outcome, and she's a happy girl. We've improved the outcome. You can see the whole change in the hairstyle, the dress, and the patient's really, really happy. And naturally, different angles, you know, and you know, we need, you know. Coming back to your questions, I've actually got some questions that I have to discuss. Could there be a better treatment outcome? In other words, you know, when you're treating clinicians and GP, I mean, was there a diagnosis error in your opinion? Treatment planning error? And then was this an unexpected result? All are possibilities, you know. Some of us can really plan well and do all the important parts, but things can still fail. Sometimes we have no control over the result of our treatment. But however, in many ways, if you had diagnosed the periodontal disease early on and explain to the patient that the implants can fail, and because you're a clinician, you have a high chance of failure rate, would that have maybe given the patient enough opportunity to say, well, look, maybe I should have another chance of having a full upper denture? That should be.
Dr. Sarkis, Johnny Dang asked, did you have to make a new lower denture too?
Yes, I did.
Okay.
Yes, I redesigned. I don't have the pictures, but I mean, I just was too busy to put the pictures on. But you know, during the diploma program, all these lectures are given in far more detail than what I give here. So if we go to detail in terms of discussing cases, designing, etc., you know, we have over 20 hours of face-to-face and another 20 hours of Zoom sessions. So you get to learn a lot in that area. So I know the thing that I like to know is that, is the medical history important? Is relevant? Yes, it is. You know, could different approach be taken for this patient? See, these are the questions I like to ask myself. So I come in usually on the weekends and you have these major cases. I like to sit down and think about this. And I always think about what happens if things fail. And that's the first thing I tell my patients is, what happens if things fail? They have to understand, they have to also accept the responsibility that things can fail. See, we are not putting blame on anybody here. We're just saying that things can happen. We can reduce the risk of our treatment, but that's only a risk. But what happens on the other end, sometimes very difficult. You can put the implant in the best position, ideal position, do ideal loading, and things fail. I've seen best treatments fail because patients felt that she's under pain, or there are those patients that think that there's always constant niggling pain or the sensation in their jawbone. So it's a very hard call for those patients. But she's a non-smoker, antidepressants, neurostomia. So something needs to think about this. Then I asked myself a question. I said, what are possible risks of bone loss with a risk assessment? Well, with periodontal disease, there's always a chance of bone loss. I don't have any periodontal charts available, so no idea what was the maintenance protocol, what was the initial starting point. I mean, there was no radiographic surgical guide, so prosthetic wasn't planned. Is it possible that full-time maxillary denture was placed during the integration period? And the patient with a severe bruxa, that would have had a loss of some bone. There's a study show that if you do lose bone when they wear a full upper denture, would that be your experience that as well?
Yeah. Yep.
And you think about here, and you can see that, at the time of presentation, there's a lot of bone loss, and the ridge is basically shrunk, that important part of the ridge. And again, implants are more buccally placed, thin bone, so more chance of resorption. You got the cover screw loss, and at the time of taking impression, it was a disease control, because I can see a lot of inflammation here, for instance. Okay, I can see a lot of inflammation. That's obviously peri-implantitis and mucositis. So this looks stable, but I'm looking at the upper left side there. There's a problem there. There's a problem there. So we have certain issues that needs to be controlled. So it is difficult for a general dentist to take on this case and construct a prosthesis. This is very difficult. Given a chance, how do you proceed with this patient? Okay, so that's a hard call for everybody, and I think that's why good communication is so important when you're placing implants with your restorative dentist. How to communicate this, and we teach it at the college. What's the important part of oral hygiene, patient assessment, patient communication? You need to understand this very importantly. See, going a bit furthermore, periodontist, patients did most refer to eventual periodontist then, and then what he did is apically position flaps to be able to gain access by good x-rays. But however, the patient didn't continue because pain was low grade but constant, nothing was getting better. And minimal follow-up with a general practitioner. So you can just see bone loss is quite apparent at the time of presentation. I would say, was there a surgical trauma? Maybe that could have contributed to the. But there's a study, and I need to get the article, that clindamycin does affect the bone healing behavior with implants. Have you come across these studies there?
I'm aware of that study, but usually with clindamycin, to what degree, I can't really say, right? Normally, patients, there's a tendency now to use azithromycin, but that is still one of the mycin groups.
Yeah, true. So that was my thinking cap, and I guess stomia depression. There's the article by Albertson trying to link it, but also it's not really maybe an association, no real causative factor. You did triage of things, and a situation. So in many ways. I'll pull out a paper at Chicago, 2017. We looked at analysis of risk factors for classic behavior dental implant failure. Looked at patients who had 3 implants, minimal, okay? And they looked at, 8,337 implants, all right? And almost 1,500 patients. And of the 592 failures, okay? Now, 4% of the patients ever failed, nearly 5% of failures, the 5%, nearly 60% of all implant failures was a patient was taking antidepressants and bruxism, was identified potential negative factors, okay, exerting statistically significant influence on classic behavior at the patient level. So that was something important to look at, because although this paper wasn't available back in 2006, but it's an important paper to understand and sometimes quote when you think, we didn't know then, and but it's something to think about this. Have you come across this paper, Stan?
Not this one. I'm not aware of this paper there.
There's a series of these papers. There's a series of these papers, yeah.
But I need to go back.
That's okay. I'll send you a copy of it. That's fine. The negative factors at the implant level, that was a patient, turn implants, short implants, poor bone quality, age of the patient, intake of medications too. This is the proton pump inhibitors, and smoking and bruxism. So it's very interesting to see that somehow there is an association, but nevertheless, it's something that the conclusion makes it very clear. It's a cluster pattern among patients with implant failure. It's highly probable. Factors of interest are predictors as for implant failures could be a number of systemic local factors, but direct causal relationship cannot be certain. I mean, we understand this, but there are risk factors that we can reduce to improve the clinical outcome. And a few more slides, which I'm going to bring up just to make people think, and I'm going to answer your question. I'm going to ask you, what was your question again, Steve?
So, who are you asking, Sarkis?
Yeah, I'm asking you, what was the question you mentioned before? You said you're changing the pattern.
No. I'm just thinking, if she didn't want dentures, what would you have done, right? There's certain patients, doesn't matter how much you convinced them, etc. They say, I don't want anything removable.
Okay, here's the concern. I actually asked the same question to this patient, and her answer was, if she had dentures that stable, she would never have implants.
So initially, it may have been better trying her on a full denture before you went down the implant.
I would make sure that I construct a good full denture, maybe twice, and try to give it a chance to think about it. And I will then explain to her, well, put it this way. Look, I have patients that are full dentures that come because they want implants. And one of the reasons they want implants is they feel uncomfortable during their personal situations. They, still young, in their 60s, they want to get in the marketplace and meet a new man, whatever, or male or female. So they don't feel comfortable with having something that's removed in their mouth. And a lot of them go dancing, etc. So they want something fixed. And even then, I still discuss all the risks associated with, with implant therapy. I will make sure that we make a really good full upper denture or lower denture as well, so they understand, and then that'll be the basis to build and plan the whole implant therapy. So you're going to start with a good removable prosthesis. You're going to start with a good full upper and lower dentures if you're planning to do implant, because you need to start somewhere. That's your best guide. That's how you decide your vertical dimension, a lot of things, your aesthetic factors. You learn about your patient, you learn about what their needs are. If a patient is going to have full maxillary and mandible implants, and you promise them a really nice smile, all this, but you better deliver it, because that's how it works. You promise, doctor, can you deliver, doctor? So most of the time, it wasn't delivered. That's where the problems occur. And you need to also prepare your patient, because especially all on fours in the mandible, you can't just put a lump of acrylic block in their mouth and say, go and deal with it. There's a lot of psychological trauma for a lot of patients. But we need to think of suitable dental special implant restoration. Advancing age, 80% of at least one chronic condition. Let more than 79-year-olds have mandibular implant, so, with 99% survival, which is great. In mandible, it works, but more problems with adaptation, right? Cheek biting, etc., which is fine. After age 80, for female, osteoporosis is higher, 4 times in males. Okay, but implant failure is not related to that. But non-estrogen replacement in postmenopausal women have high implant failure rate in the maxilla. So hormonal factors are a very important part of this. We need to think of all these factors. We need to discuss with the patients. So now, by spending a bit of time in discussing with the patient and put it in a piece of paper that the patient reads and understands, then you're in a better position to accept that, look, then implant failure maybe considers the complication. So when people talk about, 90% success rate, 95% success rate, nobody talks about that 1% or the 5% or the other 10% that it failed. For those people, it's 100% failure. So when you're going to quote a paper, it's not your paper. Like, this is not mine, but it makes sense to me. I will say this person quoted, but my personal success rate for 5 years, my personal success rate for 10 years is this. Because I've got data. I'm an experienced clinician. I'm sure, Stan, you have your own data. You know where you are. You can advise the patient, because knowledge and experience gives you feasibility. That means what you're going to do, what you're going to get to. We need to think about this. And finally, when you look at a systemic review, and this is where it comes to answer your question, by Talgi, it's Linden's group, published 2016. You know, full dentures satisfy 95% aesthetic, phonetic, functional. I just copied that, so it's aesthetic American. Functional expectations can be met. Patients that satisfy with maybe candidates for implant, maybe, not are, maybe. And a lot of them have to undergo a lot of treatment to be able to have this treatment done. So I do a lot of patients who require, we do called zygoma. I work with Peter Sakiris. We'll probably give a lecture with him next time. And for those high risk of ridges, but they know the patients, the risk involved. Now, planning some of those called zygoma is the most difficult thing to do, especially when they don't have enough areas of bone in their zygomatic, you know, arch and a zygoma. So you have to find enough bone, at least 10 millimeters, to be able to get a good primary stability. And that can be very, very difficult. How to design is very difficult. There's a lot of work goes into it. So what I'd like to conclude today's webinar is what I said initially, you know. So what's the problem today? We have lost the art of diagnosis. We're too fast in making quick doer's job, rather than sitting back and thinking, what is the best treatment for this patient? And doctor, can you deliver? Something to think about. This is what exactly we talk about in my courses, okay, in the diploma especially. It's a 2-year program. It's level 7, it's level 8 in Australian standards, okay? That's postgrad university degree that people get, okay, that allows you, that teaches you how important it is to combine all these little crappy one-day courses which you don't need, but you need a good formal education to be able to be confident in everyday treatment planning, to be confident in your treatment. And you've got a group of mentors who are really on board, who can help you. I mean, Stan's my mentor. I always ask him questions. I learn every day. I learn every day from my students. And that's what it's all about. You're joining a large group of organization that's always there to help you and support you in your everyday dentistry needs. Any questions so far?
No, Dr. Sarkis, everything has been answered. There was one question from Namita, which says, what is the alternative option if the patient is not ready for a complete denture? But I guess Dr. Stan did answer that.
Well, alternative option doesn't want complete denture is that first you to understand and look at the actual denture. So you have to understand that I like to see the prosthesis. Someone comes in and says, I'm not happy with the denture. I like to make sure that, you know, let's see the type of denture. When you look at a denture, look at a patient, look at the fitting surface, you measure a lot of things. And there may be something wrong with the denture, the way it was constructed. So unless it's a really well-constructed denture, and I'm seeing a patient got a really well-constructed denture, and they're happy with their, you know, and it looks good. All the border peripheries are sealed, and you've got a good suction, everything's fine, and they still want to have fixed option. That's a totally different, and also looking at personal history, I can understand that. But that decision I don't take lightly. I always try to make them, irrespective if you get have implants or not, all my full denture patients, whereas the maxilla or mandible, will have, you know, if they're full dentureless, they'll have proper full removal prosthesis. There's full upper and lower dentures.
Sarkis, can I take you one step back? If this patient presented when she had her natural teeth,
right,
would you have gone through the implant stage, or would you have talked her out of it and gone straight to a full upper denture?
Okay, well, that's a good question. I would look at my support system. Naturally, I wonder why they should lose a tooth in the first place.
It was through periodontal disease, right?
Well, she's got periodontal disease. Standing webinar 15 was really what you're probably asking.
Yes.
I would have first look at the periodontal support. I'll look at the general oral health. Look at us, you know, look at a history, both social and medical, dental, and look at the mobility of the teeth. Look at the occlusion. If you have a good distribution of teeth across the arch, the patient will be sent to you to give you a prognosis of his teeth. And you and I have placed so many teeth retain the fixed full upper arch, full house bridgework that's still in function after 10, 15 years then, without implants. So patient will be given a choice. Now, if there was a doubt about longevity of those teeth, I would place implants in between. I mean, I always do that, and test the system, and then remove those teeth and do a full arch prosthesis, because in the case that you have an untoward effect of implant.
Let's take that one step further. If she presented to you with a full upper denture that she was not happy with.
Right. I will reconstruct a new denture. Okay. I will convince her to give me a chance to make a new upper denture. Okay. That's a starting protocol irrespective. I would not use her existing denture as my initial starting protocol, because I would initially naturally try to realign the denture, make sure that I have extended peripheries, give it a suction, it feels better. Then that gives me a chance to say, look, maybe we can make you a new upper denture. You're happy, and she's happy. Says, you know what? I just don't want to have anything removed in my mouth. Okay, and that's fine. And then that's a good reason. But I have a new upper denture with the right, aesthetics and function and comfort at the correct vertical dimension. Then there'll be the next stage of how we're going to start and what to expect from fixed maxillary support bridgework, because you'd be losing a lot of important landmarks that, with the denture flange removed, you'd be losing a lot of, I mean, it's very complex. It's a whole area of assessing, depends on the ridge width type, and when she's fully smiling, how much ridge does it show? So that will depend if she's a fixed support implant support bridgework, or she's a implant support overdenture case. So it all depends. Thank you for the questions then.
Is there any comments from the other participants, how they would have sort of approached this particular case?
No, Dr. Stan, it's just a few comments that came in. Dr. Ryan did ask, did the patient lose tooth number 48?
Yes.
And the remaining questions have already been discussed earlier.
No, 4S is in situ, it's fine. I think the important thing is what happens from here. You see, what happens from here is the important thing, because we have this whole adult population that has had implants now for some time, and implants, we tend to lose them. And when do we place the implants? When do you hang on to the teeth? At what stage do you place the implants? So that are important questions that science hasn't really addressed the issues yet. And that's why you need to talk to your patients. So I'll bring my patients in this consulting room, and in front of me is the lecture. I will sit down, they stand, I will decide to sit down. I look at the images, I sit down, and we touch this at the college. We'll tell you how to talk to the patient, how to convey your diagnostic information, also how to listen to the patient. There's an art in diagnosis, there's an art in history taking. It's all a very important part, and you need to learn that concept. So even some of the, I can give some lecture on porcelain veneers. They're the most, I mean, today when you're doing porcelain veneers, for instance, I'm sorry to change the subject, I still see people cutting teeth immensely. I still see people leaving cements in their gum margins immensely. People are coming, I'm sure you see that, Stan, as well. And, doing, on the porcelain veneers is a gunk of residual cement. I mean, you wonder why was it left in the place, and patients got now periodontal, they lost the pillar, they like the dark spaces, they try to repair with the composite around the porcelain margin. It's all just not being taught well. This is really important. All these little 1 or 2 day courses doesn't really teach you anything. You need a formal education. That's really important. And I want you to think about this.
Sakis, I had a question about the lower arch. In many of the situations when they got a first premolar to first premolar occlusion, many patients, they don't prefer the lower denture, and they want to keep just the upper denture and lower natural teeth. Would you prefer to just keep the natural teeth, or would you like to have something?
Look, in this particular case, this has got poor prognosis, and we all agree on this, okay?
Yeah.
But if you reduce the loading here, either SRP, maybe do some regenerative therapy. Would you agree on that, Stan? You might retain his tooth.
What would you do if you had 5 to 5?
5 to 5, I'll be very happy. I'll be very happy. It's an ideal shorter than large if it's periodontal stable. Now, Kaiser's rule of SDA, that sort of only applies to class 1 occlusion and with good periodontal support. Okay. Once you have if you don't have periodontal support, I mean, I'm happy to show other cases. I have a lot of patients with failing dentition, failing bridge work. And the first thing I will do is place implants on the 6s, upper and lower, just to hold on the occlusion while we're doing therapy and for the next 12 months. But within 3 months, I could have implants up there. Okay, so I'll have a reduction of the anterior forces, anterior vectors of the teeth splaying. You hold the occlusion, you got time to recess which way to go. There's so many ways of treatment planning those patients, but you got to think ahead of time. That's important. See, really good scaling and cleaning does wonders, and you see the gum response. Okay, you see tooth improvement, splitting stabilization is an important part of it. I mean, Lindy Nyman's has a 25-year study. I mean, Lalick did a study, continue on the studies, huge studies on that. They maintain those periodontally involved teeth with hardly, 3 millimeter bone level, but with constant support periodontal therapy, people that maintain them, and that's really important. See, I'm seeing here continued bone loss, and it's a concern. Okay, because you can lose some bone, you can maintain it too. So there's a problem here that's happening. Okay.
Dr. Sarkis, Genius says patient-centric should be always the focal point of our treatment planning.
Can you say that again? I'm so sorry.
Patient-centric should be always the focal point of our treatment planning. Like a patient-centric occlusion, I think.
I'm just going to go to chat. Where's the chat?
Yeah. The last one that's come up.
Chat 8. Thank you for the questions, by the way. Patient-centric should always be the focal point of our treatment planning. Okay. Okay. Can you, all right, patient-centric. Okay. Can you write to me and say, what do you mean by that question? Because you talk about centric relation when you're doing this dentistry. I mean, obviously, is that what you meant? Just ask. Yeah. Absolutely agree with patient centric. Okay. All right. Thank you. What I would say is that when you managing occlusion, and that's another area, because occlusion is so important, not just in dentures. It's a different occlusion dentures. It's a different type of occlusal prescription on partial dentures against full dentures, partial dentures against partial dentures, partial against dentures against natural dentition. Okay, so you have to decide what is your occlusal prescription, all right, for your treatment plan. Where are you going? There's no set rules for anything. It's just occlusion is about point contact teeth. It's about transfer of neural information from one arch to the other and to the brain, to the neocortex. And occlusion is far more complex from understanding from the, we understand more about it because of the functional MRI analysis. We understand how it works, which part of the cortex it impacts. It goes to the lateral gyrus on the brain cell, the lateral sulcus, there's a centers in the brain that controls all these movements, such as the functional domesticated center. So a lot of these areas, if you haven't got any teeth, then your reference is centric relation. And centric relation is the terminal hinge axis without contact of teeth. Now, there's the teeth moving on the when it's against the condyle, we have the little hourglass shape of the condyle against the posterior superior surface of the articular eminence, so anterior part of the condyle. And the best concept to do it, there are many concepts. DOSA has got its concepts. There's many other concepts of 8 other different concepts, but normally it's much easier to take a bite in a habitual occlusion where patients comfort with centric relation is a terminal position. It's like you're walking, you can see me, it's like you're walking without falling on knees, you're walking like that. You understand? You're not following on this. So, you know, it's not a point, it's a space. And no one's really been able to define centric relation cleverly. That says it all. So it's a misnomer sometimes. If I confuse you more, it's even better. So that's why you did the diploma. And so in that way, you know, I use a lot of different modalities when you want to change someone's occlusion for restorative convenience. And you need to be able to then understand, what do I do to improve adaptation? See, the thing is that everybody wants a prescription, right? You want a prescription. You want the recipe for procedure. It's not going to happen because everyone's so different. But if you understand, you have the knowledge, you have a critical knowledge, a critical application knowledge, then you're in a position to work out the recipe for each and individual patient, you see. And that's education. You need to start reading and thinking and diagnosing rather than jumping and putting the patient at 45 degree and looking at the patient at 30 degree. I never do that. First time the patient comes to me, they talk to me here. I want to know who they are, what their needs are. All this is important. Dentistry is second nature. But how to collect the information, because most of the time patients give you the information. We just don't listen. The idea is to be able to listen and plan the treatment and not to jump into conclusions. And that takes time and takes experience. That's why we're here to give it to you.
Dr. Sarkis, we have another question by Alexander. Dr. Sarkis, in your opinion, did the type of prosthesis/prosthetic connection have a significant influence on the degree of bone loss in this patient? Would a multi-unit abutment type setup have reduced stress on the bone?
Okay. I think prosthetic design in this particular case, it's very hard to tell because I cannot say prosthetic design was a cause of the bone loss because there was bone loss starting already. Periodontal was established, and that went on because it wasn't sort of treated or arrested. If I have this particular patient and I find that, you know, there's a periodontal starting, I would remove the prosthesis. I will make a provisional prosthesis. I will change my whole design and reassess the whole situation. But don't forget, the poor general dentist received this with all the implants, with compromised bone support, and he did all his best to maintain as it is. So I think prosthetics, you can see she's a real Bruxer because the prosthesis, you can just 1 second, I'll just go back to prosthesis. Good question, by the way. See how many times she's worn into the actual in an acrylic here. Look at that. Okay. How many times she's fractured the prosthesis? She's trying to come forward. So in many ways, the design occlusion prescription could have been improved by this. Okay. I will definitely change occlusion prescription to a different format. You probably say, how would you do it? That's another hour, 2-hour lecture, or probably a whole day lecture. So you can see how she's trying very hard to go forward and bite in these areas. That was a main biting surface here, okay? There's hardly any problems over here, but also the fact that what tells me is that there was a problem with the occlusion vertical dimension as a minimal space. So that would have contributed to the actual design of the prosthesis. Going back to the full dentures, if the full denture is designed properly, you had adequate vertical dimension, you would determine how much room do you need, not to find out the sure that you have not enough room. Does that answer your question?
Dr. Sarkis, we have a question from Khan Ravi. What caused her chronic pain? Has the pain settled down after the full acrylic denture?
Pain settled down immediately when the implants were removed. So pain was caused by a chronic inflammatory process in the jawbone. You have 6 implants with large crater formation, you're in constant pain. You also have actually antidepressant therapy. I mean, this people have reduced pain thresholds, lower pain. Personally, I wouldn't implant this patient. I would refrain from doing it. And if I was doing it, I'd be doing a very careful treatment. In other words, I would make sure the patient completely understood which way we're going. And I will, you know, I would normally do 6 implants in maxilla. In a soft bone, postmenopausal, who's not taking any cortisol replacement. So in many ways, a soft bone, severe bruxa. Stephen Perel, 2000, I think 2011, he published an article on risk factors, and this is one of the risk factors for bone loss. And that's something that needs to be considered. So alarm bells go up with medications, depression, and these people can actually place severe forces on the remaining maxillary teeth. And you can see that they're the ones start to go first. You look back here. Here's your bone loss there, see? And another bone. That's your bone loss is there. So she's banging from here to there. Okay? It's simple. It's very simple. I mean, prosthesis is well constructed, but it's just a difficult case for implant support bridge work. This is something that would, in this particular case, I would simply be there, make sure that we have good, adequate thickness of bone, labially and all around the tooth. So there's no thin bone, not a middle bit. I like to have a bit more bone. I would probably use a narrow implants rather than wide implants in this case, if I have enough bone. Nothing wrong with narrow implants. I mean, we're talking about 3.5 millimeters. So whatever I would do, I would reduce and redistribute loading in this patient. And
we have another question from Alexander. Would a removable implant retained upper denture have been more appropriate treatment option in order to improve access for oral hygiene?
Okay, you know, it's a good question. Now I have a particular patient who's a puppeteer. Puppeteer is the one who put their hands in a little puppet and just makes all these noises, right? And we chose a removable denture for him for that reason, because we had to replicate his existing denture, and he couldn't. This is his livelihood. So speech was very important. I also treat a lot of opera singers who I observe their lip movements, and people who are in the entertainment business on television. So I look at how they look, and then they bring me their videos, or they all have their little programs. They bring in, I have a look and decide how we're going to design prosthesis. And in this particular case, she has a low smile line, and if you're making over denture, you still have to have the bar going right across to the denture area. So in many ways, will it improve oral hygiene or not? I don't know, because if you have individual implants and your denture is actually splitting factor, which is not really recommended for maxilla, but in this particular case, I don't think it would have changed the outcome. In other words, I think personally implants, it's only personal. Implants were in a difficult position, and a lot of bone were lost. By the time Dennis got the final to proceed with the definite treatment plan, there's a lot of bone loss, already established peri implant infection. So I don't think, it's a good question, Alexander, and thank you for that. I don't think we're going to change the course of outcome in this particular case. So when would I use, the question is, when would you use over denture instead of a fixed implant support bridge work? That'd be a fair question. Can you answer, Alexander, yes or no? Great. Okay. I think that's the question you're asking. When would you use over denture and when would you use fixed implant support bridge work? It purely depends on aesthetics, amount of lip support, and phonetics. Okay. Because you basically, denture can do marvelous effect. If the patient really is uncomfortable about wearing a denture, then if you say, look, you've got a high smile line, when you smile, your lip goes up to your nose or to your eyes, I can see the whole ridge, that's not a candidate for a fixed implantable bridge work. And that's an overdenture, because I don't want overdenture. I don't want removal, but that can't really help you. Unless you have a lip lengthening, you change your whole facial profile, it just not going to work. So they're not the candidates. The only reason I do overdentures is if the patient wants the stability, they're uncomfortable with that, full upper denture, but they don't mind having removable prosthesis, so they're used to it. So a lot of them actually feel very comfortable with removable prosthesis because they can take it out and clean and put it back in. So there's also psychological factors involved in giving over dentures instead of just simply doing fixed upper supported implant bridge work. So there's each side has got advantages and disadvantages. And the rule of dentures, of course, naturally, you have easy access to areas you can clean. That's important too. So that's an advantage of it. But you can design your fixed implant bridges for also improve hygiene access. And that may compromise phonetics as well. So how you make dentures, how you copy your dentures and replicate them back, using reverse engineering really, to do the final prosthesis that's implant supported is the key. This is a problem. See, when people tell me, oh, I can do digital, do digital imaging, we'll make your prosthesis, send us a scan files, you can try it. It doesn't work. I'm telling you, it doesn't work. I've seen it all. It doesn't work. That's why I like, we talk, a lot of participants want to know more about composites. In my course, you know more about composites and direct mock-ups and crown bridge and porcelain veneers than any other course that's ever offered, okay, at this diploma level in the world, I can tell you, okay? So that the little courses you do, you're not going to learn anything, because I see all these problems coming in my surgery for second opinions, and I know which course they have done. The important part is when we look at, for instance, diagnostic mock-up is the positional central incisor in the face. That determines which way you go, where's the implants, where's the dentures, where's porcelain veneers, where's composites, is where you start in 3 dimension in the face. That's the position you want to be. Any other questions? Been a really good question today.
Yeah, no questions as of now, Dr. Sarkis.
Well, thank you very much.
Thank you.